Digital clubbing is seen in all except aortic dissection. So, digital clubbing is seen in endocarditis, pulmonary arteriovenous fistula, and tricuspid atresia. Right branch bundle block with the left axis deviation is characteristic of ostium primum arterial septal defect. A child has cyanotic disease with left ventricular enlargement with left axis deviation. Probable diagnosis is tricuspid atresia. Clinical features of ostium secundum type of atrial septal defect are all except occurrence of congestive failure in childhood. So features of ostium secundum type of atrial septal defect are atrial arrhythmia, wide and fixed splitting of the second heart sound, mid diastolic rumble along the left sternal border. Hilar dance is seen in fluoroscopy of none of these options. Holt-Oram syndrome is characterized by atrial septal defect. A 21-year-old male presents with exertional dyspnea, raised jugular venous pressure, and loud P2. ECG shows right axis deviation. All of the following conditions are possible except ostium primum. So, which conditions are possible? Atrial septal defect, mitral stenosis, and pulmonary thromboembolism. Pulse pressure in severe aortic regurgitation is equal to 75 to 90 mm of mercury. Left ventricular hypertrophy is not a feature of isolated mitral stenosis. So, left ventricular hypertrophy is a feature of mitral regurgitation, isolated ventricular septal defect, and aortic stenosis. Which one of the following is characteristic of mitral valve prolapse syndrome mid-systolic click? Angina and syncope in same patient is seen in aortic stenosis. Findings in a case of advanced mitral stenosis include low pulse pressure. Aortic regurgitation is seen in all except myocardial infarction. Aortic regurgitation is seen in rheumatic fever, infective endocarditis, and Marfan syndrome. Acute aortic regurgitation occurs in infective endocarditis, ankylosing spondylitis, and Marfan syndrome. In valvular aortic stenosis, poorest prognosis is indicated when dyspnea occurs. Aortic regurgitation may be associated with all of the following except polyarteritis nodosa. So, aortic regurgitation may be associated with ankylosing spondylitis, Marfan syndrome, and dissection of aorta. Regarding rheumatic heart disease, consider the following statements. So, which of these statement given above is correct? So, what is correct is first one, rheumatic carditis is a pancarditis, and third sentence that mitral regurgitation is the in most common manifestation of acute rheumatic carditis. A patient of rheumatic heart disease with mitral stenosis and atrial fibrillation is on oral warfarin. On one OPD visit, his INR is found to be 6. What is the action to be taken? Stop warfarin and review. Severe chronic mitral regurgitation is associated with H3, left atrial enlargement, atrial fibrillation, and displaced apical impulse. Where pulsatile lever and ascites is found, tricuspid regurgitation. Coarctation of aorta is most commonly associated with bicuspid aortic valve. A 38-year-old man presents with chest pain and shortness of breath. His pulse rate is 85 per minute. Blood pressure is 150 by 118 millimeter of mercury, and the cardiac auscultation reveals an ejection systolic murmur. The ECG shows left ventricular hypertrophy pattern and ST depression in the anterior lead. His troponin test is positive. The echocardiogram of the person is likely to reveal aortic stenosis. Mid-systolic click is characteristic feature of aortic regurgitation. A 40-year-old female presented with dyspnea on exertion, grade in and palpitation. ECG shows atrial fibrillation with fast ventricular rate. Echocardiography shows several mitral stenosis, severe mitral stenosis with left atrial appendage clot. Which of the following is not advised? EC followed by percutaneous balloon mitral valvuloplasty is not advised. What is advised is diltiazem to control ventricular rate and start warfarin and follow up with repeat echocardiography and open mitral commissurotomy with clot removal. Sudden death can be seen in aortic stenosis. Subaortic stenosis is not associated with aortic regurgitation. S1 ejection click and severe pulmonary stenosis relation is in severe pulmonary stenosis gap reduces. Now myocardial infarction, all of the following are risk factors for atherosclerosis except decreased fibrinogen levels. So which are the risk factor of atherosclerosis? Increased waist hip ratio, hyperhomocystinemia, decreased high density lipoprotein levels. Risk factor for coronary artery disease CAD is increased homocysteine level and increased lipoprotein. Diagnostic criteria of metabolic syndrome include high serum triglyceride and low high density lipoprotein cholesterol. All of the following dietary goals are recommended for patients with high risk of coronary heart disease except avoidance of alcohol. So what is indicated dietary recommendations? LDL cholesterol should be less than 100 mg per deciliter. Saturated fat should be less than 7% of total calories, and salt restriction should be less than 6 gram per day. In an old patient, the best indicator of probability of developing cardiovascular disease can be calculated by LDL-HDL ratio. Which of the following about atherosclerosis is true? Intake of unsaturated fatty acid associated with decreased risk. Best predictor of cardiovascular risk among the following: C-reactive protein, that is CRP. Treatment with W3 polyunsaturated fatty acid, what will be the lipid profile? Increased LDL and decreased total cholesterol. Most important predictor of coronary artery disease is LDL-HDL ratio. Best predictor for coronary artery disease is LDL, low density lipoprotein. A patient presents 12 hours following a myocardial infarction. Which of the following enzymes will be elevated at this period? Creatinine phosphokinase. Troponin T is preferable to CPK-MB in the diagnosis of acute myocardial infarction in all of the following situations except reinfarction after 4 days. So it can be troponin T is preferable to CPK-MB in diagnosis of MI. In which conditions? Bedside diagnosis of MI, postoperatively after CABG, and small infarcts. In myocardial infarction, which enzyme is raised in 4 to 6 hours and decreases in 3 to 4 days? CPK. In stable angina, the levels of cardiac markers remain unchanged. A 60-year-old man presents with chest pain which lasts 6 hours and is diagnosed as acute myocardial infarction. Angiography showed involvement of anterior descending branch of left coronary artery. The most probable site of infarct is anterolateral valve. All of the following arteries are common sites of occlusion by except marginal artery. So which are the common sites of occlusion? Left anterior descending, right coronary artery, and circumflex coronary artery. What is the diagnostic of fresh myocardial infarction in ECG? ST segment elevation. ST depression and T wave inversion in 4 to 6 in V1 to V6 and a VL lead indicate anterolateral wall acute myocardial infarction. ECG is least useful for diagnosing ischemia due to involvement of left circumflex. ECG sensitive to detect ischemia is our lead 1, lead 2, lead VF, lead V2. All of the following statements regarding the ECG in acute pericarditis are true except T wave inversion developed before ST elevation return to baseline. So what is true about ECG in acute pericarditis. Global ST segment elevation is seen in early pericarditis. Sinus tachycardia is a common finding. PR segment depression is present in majority of patients. Universal definition of myocardial infarction: all except 3 times increase in troponin level after coronary artery bypass is wrong. Sudden death can be myocardial infarction. New abnormal valve motion with raised cardiac biomarker. Reperfusion in 5 to 7% leads to elevation of troponin levels. Ram Kumar, a 70-year-old hypertensive male, was admitted in the intensive care unit with transmural anterolateral myocardial infarction. His condition was stable till 5th day of admission, when he developed a pericardial friction rub and pleuritic chest pain, which persisted despite narcotic and steroid therapy. On the 7th morning, he suddenly developed marked hypotension. On examination, there was marked distension of the jugular veins, accompanied with electromechanical dissociation. Most likely, the patient had developed external cardiac rupture. In a patient with myocardial infarction, the valvular lesion commonly seen as mitral regurgitation. Post-myocardial infarction systolic murmur in left lower sternum may be due to all except complete heart block. So, which are the causes which can cause post-MI systolic murmur in left lower sternum? Rupture of interventricular septum, papillary muscle dysfunction, and ischemic cardiomyopathy. A patient had an inferior wall myocardial infarction and was in shock. The reason for the patient being in shock is right ventricular infarction. A patient with acute inferior wall myocardial infarction has developed shock. Which of the following is the most likely cause of shock? Right ventricular infarction. A previously healthy 58-year-old man is admitted to the hospital because of an acute inferior myocardial infarction. Within several hours, he becomes oliguric and hypotensive. Blood pressure is 90 by 60 mm of mercury. Insertion of a pulmonary artery Swan-Ganz catheter reveals the following pressure: pulmonary capillary wedge 4 mm of mercury, pulmonary artery 22 by 4 mm of mercury, and mean right atrial 11 mm of mercury. This man would be best treated with fluids. In a patient of acute inferior wall MI, best modality of treatment is IV fluid. Which test is performed to detect reversible myocardial ischemia? Thallium scan. Test for reversible cardiac ischemia: thallium scan. Reperfusion is useful for hibernating myocardium. Volume of infarcted area in acute myocardial infarction AMI can be detected by echo and thallium scan. Drug used to perform stress echo: dobutamine. All of the following drugs are used in the management of acute myocardial infarction except calcium channel blockers. So, which drugs are used in management of acute MI? Tissue plasminogen activator, intravenous beta blocker, and acetyl salicylic acid. The treatment of acute myocardial infarction include which of the following? Aspirin, heparin, alteplase, and ACE inhibitor. A patient presents with intense chest pain of 2 hours duration. ECG shows ST depression in lead 1 and 5 to W. There is associated T inversion and CPKMB is elevated. Which of the following should be included in his management? Nitroglycerin drip, aspirin, coronary angiography, and IV metoprolol. The best possible intervention for acute myocardial infarction is early primary coronary intervention. A 40-year-old male chronic smoker comes with acute epigastric discomfort for past 1 hour. ECG showing ST segment elevation in inferior lead. What is the immediate intervention? Aspirin. A 50-year-old man with a history of smoking, hypertension, and chronic exertional angina develops several daily episodes of chest pain at rest compatible with cardiac ischemia. The patient is hospitalized. All the following would be a part of an appropriate management plan except lidocaine by bolus infusion. A man with chest pain, ST segment depression, and lead V1 to V4 after 1 hour will not be given thrombolytic. Agent of first choice in an acute attack of prensyl metals angina is nitrate. A 70-year patient is refusing for angiography, but he has an episode of chest pain on walking upstairs. Not progressed for last 4 years. What should be done in this patient? Aspirin low dose given, nitroglycerin sublingual before walking upstairs. In myocardial infarction, following are used except plasminogen activator inhibitor. So what is used is fibrinolytic, antithrombin and platelet inhibitor. Complication of streptokinase are intracranial bleed and anaphylaxis. Streptokinase and urokinase are contraindicated in intracranial malignancy. Exercise testing is absolutely contraindicated in which one of the following? Unstable angina. Exercise testing is not contraindicated in 1 week of following myocardial infarction, aortic stenosis, and peripheral vascular disease. Poor prognostic factor in acute myocardial infarction is hypotension at diagnosis. For the management of intraoperative myocardial ischemia, all of the following are advised except heparin. So, what can be advised? Intravenous nitroglycerin, calcium channel blocker, and atropine. A patient presents with acute anterior wall infarction and hypertension, which will be the immediate treatment modality for this patient. Intra-aortic balloon counter pulsation. Following an acute attack, Following an attack of myocardial infarction, the mortality and morbidity of the patient is indicated by left ventricular ejection fraction. Which of the following is not a Framingham major criteria for the diagnosis of heart failure? Hepatomegaly is not a major criteria. Paroxysmal nocturnal dyspnea, cardiomegaly, and S3 gallop are the major criteria for the diagnosis of heart failure. Which of the following dietary intervention reduces the further risk of MI patient? CO3 polyunsaturated fatty acid. Drug used in unstable angina and NSTMI: morphine, aspirin, nitrate, antithrombotic therapy, and CCB. Reperfusion is useful for hibernating myocardium. Which of the following about atherosclerosis is true? Intake of unsaturated fatty acid associated with decreased risk. Diagnostic criteria of metabolic syndrome include high serum triglyceride and low high density lipoprotein cholesterol. Cholesterol level for preventing of coronary artery disease is less than 200 mg per deciliter. Atherosclerosis is seen with which bacteria? Chlamydia. In two patients with atherosclerosis, one is diabetic and other is non-diabetic. In relation to non-diabetic, diabetic patient has 100 times increased risk of lower limb ischemia, which can cause profound hyperlipidemia, hypothyroidism, reinfarction after 8th day, troponin, cardiac marker diagnostic on 10th day of myocardial infarction, troponin. An elderly female presents to the emergency department and was found to have a transmural myocardial infarction. Based on her ECG, she was started on thrombolytic therapy with streptokinase. On further examination, which of the following findings would indicate that the thrombolytic therapy is risky and should be stopped? Significant pericardial effusion on echocardiography. The treatment of a patient with myocardial infarction is thrombolytic therapy if the patient presents within 24 hours of chest pain. Congestive heart failure. Peripheral edema in congestive cardiac failure is due to increased sympathetic tone and increased hydrostatic pressure. In congestive cardiac failure, there is oliguria. Congestive cardiac failure is associated with increase in all of the following except serum sodium. So what increases? Right atrial mean pressure, serum urea, and serum norepinephrine increases. Most common cause of acute right ventricular failure is massive pulmonary embolism. Radiological features of left ventricular heart failure are all except oligemic lung fields. So which are the features of LVH? Curly B lines, cardiomegaly, and increased flow in upper lobe veins. Drug used in heart failure is ACE inhibitor, hydralazine, and carvedilol. In a patient with chronic congestive cardiac failure, all of the following drugs prolong survival except digoxin. So metoprolol, carvedilol, and enalapril is indicative in chronic congestive cardiac failure, prolonged survival. In congestive cardiac failure, all are true used except trimetazidine. So what is used is spironolactone, nitrate and naceritide.